So we all know that DBS is a very effective therapy for multiple things, especially the Parkinson's disease. And we all know that precise localization is very important. If you hit the target right on, it makes everything easier. Programming and the therapy is very effective. And the most common practice now across the country is still keeping the patient awake with MER and either use frame or no frame. And external OR imaging is more common, and some have intraoperative imaging capacity. So this is where things get a little bit confusing for us, whether to do the surgery awake, asleep, some benefits for each, to abandon MER altogether or not, or to keep it alive, to use some kind of robotic assistant, although that's kind of the gravy, that's not the real thing. Also, intraoperative imaging, how important is that? How does this change the way we do things? Does it improve it? Does it improve our workflow, patient safety? How does this all pan out? Those are the questions we had. So when I was training, this is what I had to do. I stood behind my mentor, Dr. Burchell, and just kind of watch him for hours and hours. And this is kind of the thing that was going through my mind, because he's like, oh yeah, that's STN. Okay, great. So, and there are a lot of evidence now saying, using high field MRI, group at UCSF has demonstrated that this is a really viable option. Not everybody can afford a high field intraoperative MRI except, big academic centers. And they demonstrated that the error is very low. You can very effectively using some sort of intraoperative imaging technique with MR, no MER with the patient asleep and have pretty good outcome. And also, a lot of people are looking into some sort of imaging technique like the O-arm, and a lot of people already use frameless technique, and that's nothing new. And my mentor, Dr. Burchell, was the one who said and wrote a book on MER, and 20 years ago he said, if you don't do MER, you're not a functional neurosurgeon. But last year at the AANS, he kind of said, oh, you don't need MER. Now, it's really easy for him to say because he's the authority, but what about me? Like I learned this and it's stuck in my head for 20 years that you have to do MER. And now all of a sudden I'm being told by the authority, well, you don't need MER. Well, the bottom line is, well, if the patients do well, okay, you don't need MER. And he has shown that in his series that the patient did very well as they ever did for all these operations without the MER being asleep using a intraoperative imaging. So robots, we have lots of different kind of robots. This is the one we use at UCI to do all the surgery. So, and it goes back to 1988. And the first robot was used in neurosurgery by Kuo et al. This robot had arm and 5 degrees of freedom. And they even used robot to take out some brain tumors in the 91s. And this was kind of the first FDA-approved robot in 1999. It was done in France, used by Benebit. And there are other types of robots. For example, there is the MER robot, really designed for spine applications. But now they have also jumped on the bandwagon saying that we can use this for brain application. So this robot, unlike the one, the Rosa, you have to mount the robot on the head. So it's kind of like a next frame. It's very local, and all the coordinates are calculated based on that. So the Rosa robot was put together in 2007 in France, and it was not until 2012 that's FDA approved. This robot, unlike the MER robot or the other frameless technology, it doesn't sit on the head. It's actually floating in space. So the trick is to connect this with the head without the attachments directly on the head. And they've shown that with laser, the accuracy was okay. It was 0 to 2 millimeter. With the bony fiducial, they can get the accuracy down to 0.3 to 0.72 millimeter. So with the fiducial, it was definitely better. And that's how they got through the FDA approval here with the bony fiducial for DBS. So Rosa has been used widely, probably in maybe 20 centers in North America. A lot of application in the SEEG lead placement. With SEEG, your accuracy doesn't have to be so high. You can just basically put the lead near the amygdala, hippocampus, and you don't have to be so accurate. That's been widely used. And the advantage is obvious. You can put 20 leads in without changing the frame. And it's very, very nice and quick. How about DBS? Well, accuracy is very, very important. If we want to get rid of the ARC, the frameless apparatus, we better be sure that the accuracy is checked to the best possibility. The advantage of this is obvious, frameless, but you have other technology. But also you can incorporate the registration of the process along with the planning and everything all together in one, and the navigation as well. And also, you can make minor adjustments with the robot arm to adapt how you want it to enter and the trajectory. And also, changing side is very easy. Like after you're done with the left side, you push the button, it goes to the right side, instead of reaching under the drape or fiddling with the dials to change the size. So we did the first case, and it went obviously very well when we published the result. And subsequently, we've done probably like 30 cases now with this robot. And to get it to work, we had to do a lot of kind of background testing. And we used the Phantom. And the key here is actually you still have the frame. I mean, it's kind of dumb, but you have to put the head in some kind of holder. You can use any Mayfield head holder, CRW, BRW, Lexel, but you still need to fix the head. So the frameless concept is kind of weird. But the key here is actually this arm to fixate that really rigidly to the head. So the relationship between this is fixed. So this floating arm is really in a well-defined coordinate system. So we went through very tedious testing, and as you can see, you can still hold the micro drive. Hence, we try some MER. So again, this piece actually took the company 6 months to make, and I don't know if it's because it's in France, different work ethics, but it actually the engineer, we visited the company, and 6 months later they mailed us this device. So a sleep DBS, and I think already a lot of the surgeons here do it already, and patients, if you give them a choice, they're going to say sleep. And is it safer? Maybe, airway is secure. You don't have to worry about that. And the patient shaking is not going to change the coordinates. Potentially, it decreases the OR time because you don't have to listen to the patient. You just kind of move through it. Also, maybe it decreased the cost. Dr. Bergman in his paper mentioned something like that. But the potential limitation, well, if you pay the patient to sleep, are we going to lose the ability to do MER? And there was some information on that, and some say yes, some say no. And we're not going to get the patient feedback. You're really nervous about doing the essential tremor cases. Also, how accurate are we? So intraop imaging, you can use CT or MR. MRI is very expensive, and you have to have all the tools that's compatible with that. CT scan is a little bit cheaper, and it's actually more accurate, believe it or not. And the benefit is you can do the scan right in there. You can do the planning, registration, everything together. You can check the placement right after the surgery. And if there's a need to move the lead, you can do it right there without going out to OR and coming back. The potential limitation is it's expensive. It increased the OR time. OR time is expensive. So this is what we use in UC Irvine. We have a BodyTome, which is a big bore CT. The Ceratome has the thing, and it's much, much smaller. You can barely fit the head in there, not to mention the frame. So if you're using a frame, you can still use this whole thing. This whole thing can slide over the entire body, so it's very, very nice. And you can see how this is a case we did with a frame and MER inside of the body tome. And I call this the most expensive holder for the drapes. So which anesthesia, and there are a lot of data on which agent to use. Presidex was one of the better ones, propofol. So we just had long meetings with the anesthesiologists and kind of came up with our protocol. This is our protocol. We use propofol, fentanyl, and we use BIS monitor taped to the forehead. And while we do the burr hole, we keep it at 40. And when we want to do the recording, we lighten them up to 60 and 70. So there's some indicator on how deep the anesthesia is. So now moving forward to the arm, robotic arm. This is the Rosa in action. You can see that it's very similar. We still use the body tome, the drapes, and now there's no frame, obviously, and the robotic arm kind of floats in space. So typical incision, this is no different. Again, this is a Lexel base frame, not used as a frame. And then the incision and the fiducials, we need 5 fiducials, and again, the French engineers did a bunch of tests to say 5 is the best number. And this is how kind of the workflow. We do the MRI anytime ahead, and in the OR, we put these 5 bony fiducials. In the beginning, this took like an hour. Now it takes 5 minutes. So now we do the intraoperative CT and do the registration after you merge the CT with the MR. So the Rosa kind of, you have to touch all those 5 points, and it does the accurate registration, and you drape it. And now you can use the pre-planned trajectory, and the robot moves in position, the left side, and you can mount the micro drive and do your micro electro recording, and then implant the leads. And now it moves to the right side with one touch of button. You don't have to fiddle with the frame or a frameless frame. And same thing, you implant. And after that, we check the CT right away. So I'm going to talk about the operating time a little bit. So it happened that everything was good, but there's a little bit of glitch. When they designed that piece to attach the head to the robot, there was that buttress that comes out at 45 degrees. That was crucial for the stability of the system. However, when you want to, one thing we didn't take into consideration is when you move the body tome in, the body tome is very, very thick. That 45-degree buttress actually prevents the body tome from coming in completely. That's something we learned the hard way. So now we're going to go back to France and have them design another piece that's not 45 degrees, maybe with more attach points. I'm waiting for that, maybe another 6 months, I'll get that piece. So accuracy is kind of the summary of our data. It's fairly good. I mean, in the X direction, you're looking at 1.08, Y 0.91, Z is 1.75. And when you look at the vector, it's about 2.53, which is fairly consistent with the literature, and which was shown below. So again, there's some discrepancy with accuracy when you look at the right side versus the left side. Nobody's ever explained that to me, but we've noticed that when we look into the literature, it's there as well. I don't think anybody pointed that out. So on the right side, you can see the entry point is easy. We're very close. But once it gets down to the target, it's on the order of, on the right side, 1.68. On the left side is 1.14. Do you guys have any idea why on the left side is more accurate? Yeah.
We noticed either first or second side.
Okay.
Not necessarily left or right.
Yes.
But benefited doctors documented that the right STN is smaller than the left STN.
Ah,
And so we always find the right a little bit more difficult, especially if the right is the second side.
okay.
But we also, you're doing them in the optimal position as they are in the scanner. So we have them up a little bit sitting. So there's a little
Air.
we probably in training more air than we would like.
Right.
I think that's one of our issues.
Okay. But I mean, but you have noticed the discrepancy with the left and the right too. Okay.
Is your right first or is your right second?
We usually do the left side first. So that's, you know, the dominant side, we usually do that first. So that may, yes. Okay. Well, when you're authority, you can say anything you want. Okay. Right. Okay, so more confused than ever. So again, this is a paper from France, and they actually were way ahead of us. I mean, they've been using this robot for maybe 200 cases now. So they published their results, which is very similar. Again, their conclusion was that you can bone leaf fiducia was essential compared to the laser, and that's how they generated the data to get the FDA approval. So what about intraoperative MER with anesthesia? And this is kind of what we learned. And I don't know how, this is not very scientific. Again, this is just kind of a crude analysis. The signals are there. They're a little bit smaller. They come in a little bit later. Like, with the awake patient, you put the MER microelectrode in, boom, it's right there. You can see it right away. For this, you can drive it there, and you kind of have to sit there for a couple of seconds, sometimes 5 seconds, and it kicks in. And it's consistent. It's there. It kicks in. And the frequency is a little bit lower. So it's still very, very useful because we use this mainly to kind of check the depth, like, check the SNR, and also and we use the bang gun for 3 tracks, the center, anterior, lateral. And here, this is very small. I don't know if you can see it. So we kind of look at our frame and robotic cases. Usable recording, and these are all asleep MER, 54 out of 60. And with the robotic, 34 out of 34, they were useful recordings. And 50 out of the 60, we left at the central tract. And there's an algorithm we go through. We have the neurophysiologist there, and they have a checklist to see, are we really convinced that another track is better? And then we really, really challenge them to make that call. And if they say, okay, this is overwhelmingly convincing, then we'll change the lead to from the center to either anterior or lateral. So you can see with the robot, 2 were anterior and 4 were lateral. And there's something that we noticed that the distance of recordable STN is smaller in our asleep patients compared to the literature. So, and I don't know exactly why that is. Probably it's just like the signals are diminished. Maybe you're not as sensitive in picking up all the signals. So that may explain why. And also there's a discrepancy with the frame one. It's actually longer STN we can record compared to the other ones. So the frequency were a little lower than the awake recording. So is this useful? I think so, because not all of them end up where we thought we were going to put it. So without the recording, we would have put all the leads in that position. But with the recording, we actually modify where we eventually put the lead in. Without that information, I don't know how you would decide. But some interesting observation too is after we chose to go with physiology, that was overwhelmingly convincing, and we checked the imaging after we placed the lead, it was right on. So where did the error happen? I don't know, probably, error can happen anywhere in the chain, so it's very hard to tell, but having that reassurance actually helped us. So the question, can we obtain MER? Yes, but at a lower frequency, lower amplitude, and a little bit delay. But it's still there. It's still useful. And how about the outcome? I mean, again, the outcome will show that, DBS is very effective, and that really didn't change. Using any of this thing really didn't change, which is consistent with what other people are publishing as well. So operative time, this is where the problem comes in. With a frame, both sides, it took about 200 minutes. This is with a sleep intraoperative recording. With a robot, we're adding quite a bit of time, almost an hour. And obviously, this is not what we want to see, but there's some learning curve involved. For example, those fiducials, in the beginning, it took a long time. We took a blade and made a little cut, and the way it goes into the bone is very tricky. So, and then now, actually, my residents can do it in 5 minutes. If it takes me an hour, they can just go in and do it 5 minutes. I said, okay, well, you do it. So are there any difference in different targets? No, it's consistently that it takes longer in the robot, which makes sense because it's the process, the preparation, the registration, that's taking the time. So how happy are the patients? Well, most of your DBS patients love you because this is a very good therapy. So using the robot, putting them to sleep, really didn't make any difference. They're all very happy. The green one is the one that said, well, okay, I'm not going to recommend this to my patient. And the same patient was the patient who had a complication, so that was a no-brainer. And again, I don't think the using robot or a frame differentiates what complication you're going to have. I don't see any specific reason for you to have a complication because you use the robot. Well, maybe the time is longer, but our infection happened in the frame case. And we had a subdural hematoma with a venous infarct in that patient. And that patient was not happy, and he was not going to refer his friends for DBS surgery. So in conclusion, we found that MER is still useful during a sleep DBS. It's like training wheel for me. I feel a little bit hesitant to just take them off at this moment. Intraop CT confirms lead placement. Robotic DBS has some advantage and benefits, although we're still on the very learning steep curve. The accuracy is actually equivalent or maybe a little bit better than what's published in the literature with other technology. So we'll see where this goes. I'm as confused as I am before I started. So.
Thank you very much.